From this, we'll move to another last case. Will be presented by Dr. Altayyeb Yousef, interventional cardiologist, head of cardiology at the Booth Cardiac Center in Kuwait. Stage is yours, Dr. Altayyeb.
Okay, so my name is Altayyeb Yousef. I'm a structural interventional cardiologist and a head of department in the Booth Cardiac Center. I'm presenting a case, a challenging case that we came across, I think, a couple of months ago in a sick patient about transcaval access. The case, in short, it was a 68 male non-Kuwaiti patient who presented with hypertensive emergency and required non-invasive ventilation for heart failure. The past medical history of this patient, he has severe AS. His mean gradient was 44 millimeter mercury, and he had an LVEF that was borderline 50%. And he had an estimated aortic valve area of 0.7 centimeters squared. Apart from that, he's diabetic, hypertensive, dyslipidemic, and he has ischemic heart disease, among other less relevant past medical history. The patient was CAT and was deemed that the TAVI here is only for Kuwaitis, and he was deemed to go for SAVR. However, the patient kept refusing. I personally had probably at least twice, if not 3 times, family meetings, including his daughter, who is a nurse in our hospital, and explained to him why we're choosing the SAVR option. Despite having recurrent chest pain episodes over a week, he kept refusing, and those retrosternal chest pain episodes had significant ST depressions. At one night, he basically early in the morning, he arrested, and during arrest, he aspirated and arrested, and then he had an immediate and effective CPR, and after a 2-minute cycle, he basically we achieved ROSC. He was taken to the cath lab immediately, and ECMO and intra-aortic balloon pump were placed at that night. Also, we were contacted, the structural team was contacted. Unfortunately, I had a flu that day, actually, and I was all the time in bed, but call of duty, so we had to come in and help this patient. So this patient had a left side ECMO, right side intra-aortic balloon pump. Initially, I've given him an attempt of stopping the intra-aortic balloon pump so we can switch and put the TAVI through it, but he did not tolerate, and his blood pressure was tanking, actually. So given the fact that he needed both, and given that transcaval access was the access to go to where I trained, so we went with transcaval access as an emergency basis. So through the right femoral vein, we went on and we accessed. He had a nice non-calcific aorta. Ideally, you should have a biplane machine, but we don't have in my center, so we went with the old style single plane without CT mapping, and we went basically and we went through the aorta with a stat wire. We poked through the aorta and through the inferior vena cava through the aorta, and then basically we snared the wire, and thereafter we did a serial of wire conversion, and we delivered the valve. After the delivery of the valve, we deployed the TAVI the usual way, and on the way back, we simply occluded it with the ADO occluder. The sealing was excellent. The blood pressure was stable throughout the procedure, and the patient was left the cath lab in a stable condition. However, it seems that he also developed a septic shock at the same time from the aspiration. It's hard to tell exactly the mechanism, but we were able to take off the intra-aortic balloon pump afterwards, but we were not able to take off the ECMO. So I'm going to talk briefly about alternative non-femoral TAVR access here. So there are numerous access, alternative road access other than femoral being the gold standard. Those include transcaval, transaxillary, and transcarotid. And in the new era of using shockwave, the role of these alternative accesses have diminished greatly. Transcaval initially, there was an initial reported major bleeding of 12% compared to the others, which considered to be initially to be significant. However, with developing experience and using more techniques, that rate, I can tell you from my experience where I trained in my year of training in 2017, 2018, we've done about 25 transcaval access, and I can testify that we did not have a single complication. The only complication we probably had was thrombocytopenia, and in majority of cases, it resolved spontaneously within 2 days to a week. The other advantages of transcaval access, it's elegant, it's you basically have a device success of 100%. You don't need a cover stent in the majority of cases, and basically you can use it for multitude of things, like if you need an Impella 5.0, for example, it can be done quickly and safely as well if you know what you're doing, basically. And most importantly, in my opinion, what's characterized transcaval, which is a little bit interesting, that you see in this data that transcaval is associated with 5% risk of stroke, comparison to transaxillary or transsubclavian, which is 1%, which is a little bit odd because, again, like transcaval, you're coming from below, not coming from above, unlike transaxillary or subclavian, but this was published in one of the studies. I hope this was a brief introduction about the case, and I'm happy to address any questions about the case or about the concept of transcaval. Thank you.
Okay, great case, Dr. Altayyeb. I think it's always challenging to go to transcaval. It's not something we see it always. We hear about it. Dr. Rashal Bardi present a case to us in one of the conferences, and just to take a very quick comment, and if there is a very quick question, we'll handle it. We have only 2 minutes before we conclude our session. Dr. Faisal?
Great case, Dr. Tayyib. This is not for any center. We really need to concentrate on the techniques. Probably you got excellent training in this technique. One of the best centers who do that, but some center, high volume center, does not do transcaval regularly. Also, there is a set of complication that we are not comfortable with as an interventional cardiologist to deal with. It's in the area of the vascular surgeon. So for people who are watching this, it's beautiful demonstration, but I do believe that we have to keep it in some expert center who know how to deal with such complication, and you have to have a vascular surgeon on board for such great demonstration. Thanks, Dr. Tayyib.
Great. Dr. Fadi?
Don't do this at home alone. That's my tip. Yousef trained at one of the best centers that doing transcaval, and he has great skills. I've shied away from transcaval lately because I felt that I don't need it anymore. So I will go transfemoral, then shockwave transfemoral. Then my second access is percutaneous axillary. So I really did not have any. I mean, I don't see the need anymore for transcaval, although it's a very elegant technique, and especially like you said, sometimes you want to use ECMO Impella. It will be a very good access. But excellent case, and congratulations.
Good. Dr. Mohammed Al-Ataybi, 20 seconds.
It's an excellent case, but what really analyzed, as in addition to what Faisal said, we should have a CT scan. It's a prerequisite. We don't want any structure that comes between the inferior vena cava and the aorta, and you pierce it with you. So I think that's very important point. But it should be done again by specialized center, specialized people.
Great. We have to conclude now because we have a patient on table from France with Dr. Antoine Lafont. Thank you very much. It was a great session, a great start with the senior interventional cardiologist expert in coronary and structural. We learned a lot from our first session today. From that, I will hand the mic to my colleague, Dr. Abdelmajid Al-Zubaydi from United Arab Emirates to moderate a live transmission by Anthony Levent, TAVI challenging case from France. Thank you very much, and please stay with us.
Thank you.